So I'm in New York, and I thought that you might like to be reminded that as well as this current surge affecting Europe, it's also affecting North America, and the consequences, as you'll hear in a minute, are quite serious. Let's go around the world and tell you what we're picking up. First of all, the Chinese government is still doing everything possible to try to prevent people from being infected with COVID-19, and they're using movement restrictions as a primary means of control when they've got big surges. So the city of Wuhan, where first COVID-19 cases emerged, has been partly locked down nearly 3 years after this started. That's 800,000 people asked to stay at home, as Chinese cities from Wuhan in central China, Shenzhen in the northwest, are doubling down because they want to do everything possible to try to stop spread. I am not saying this is tactically wrong. I'm saying it's a strategy that may well turn out to be quite sensible in a number of respects, and I do not want anybody to think that I see this as mistaken, but I've noticed that in a lot of the reporting on this stay-at-home strategy, there are comments to suggest that it's excessive. Well, the key thing is, what are the long-term dangers associated with COVID infection over and above the immediate threat of mortality? And there may well be a strong epidemiological case for taking greater action to reduce transmission than is being done in some Western countries, including in Europe and North America. And for me, the issue is still an open question. And I'm very, very keen that in these briefings, I convey this to you. We might well want to discuss it. You see, I've had a correspondent who's written to me several times recently saying, in the UK, how can we reduce our risk given that very few people are masking and practicing physical distancing, and we're basically behaving as though we're sort of back to pre-pandemic behavior. Now, my response is obviously, if a society has decided collectively that it's not going to take precautions, it's extremely difficult then to actually help individuals. I've noticed in my transatlantic traveling recently that there is definitely about 10% of travelers who wish to remain masked, even though the mood is shifting. And I think that's quite important to note, that there is, even in Western Europe and North America, a proportion who are not ready to ditch their precautions. Now, I wanted to spend a minute about focusing on New York. In this city and in this state, what appears to be happening is that there's a combination of COVID influenza and respiratory syncytial virus outbreaks affecting the population, hospitalizations rising, and Omicron is still the group of variants that's affecting people here in New York when they're affected by COVID. But the situation has changed since the summer, because in the summer it was BA.5, the subvariant that was causing most of the infections in this city. But it's now more of a cocktail of variants, a mixture of different Omicron subvariants, including BQ1 and BQ11, which are even more transmissible than the earlier Omicron variants. And what does this do? It means that there is a much greater likelihood that as these newer variants start to spread, that they will be better at dodging or escaping the varied patterns of immunity that now exist in different settings. And it's going to be quite difficult to neatly match together the viruses to which communities are exposed and the immunity that exists within communities, given the varied immunization schedules that are underway, and also given that there's also been many intervals since people were first infected. And so what I'm suggesting to everybody is that we see this as a cocktail of variants and extremely varied patterns of immunity in individuals and communities, thus making the forecasting of how serious different outbreaks are likely to be increasingly difficult. But within all this, the message is, one, please do get yourself immunized. You should be up to, in my view, if you are in my sort of age group, 4 injections certainly with vaccine, and perhaps you might even be moving towards 5. Some will be wanting to make a point of getting the new bivalent vaccine that includes Omicron as well as the original virus variants. That would seem to be sensible, particularly for people who've got higher risks. Now, I want to just add that we've got lots more evidence of the difficulties happening as a result of COVID. First of all, long COVID, only a fraction of sufferers are getting help from the National Health Service in England. I mean, I think this is clearly going to be an enormous issue everywhere. The figure for the UK was about 60,000 of an estimated 277,000 who are eligible are being seen by specialist services. And we've got lots of other information that many of you will have seen, just to remind us that UK health services are really exceedingly stretched in terms of functional performance at the moment for a mix of reasons. And that's going to get worse, obviously, in the winter. And so there are some super difficult choices having to be made by people who are working in the health service, who came in to the work because they wanted to help people. And now they're having to make decisions that they know will lead to a kind of rationing that results in suboptimal care being given to certain groups of people. There's just no alternative, given staffing shortages in particular. I mean, this is an issue for governments to deal with, but it's also an issue for health service managers. But nobody, I think, who's studying what's going on can walk away saying it's anything other than amazingly serious in the UK, but also in France, also in Germany, also in parts of the United States and in Canada, where I was a couple of weeks ago, because the capacity to deal with patient load is greatly reduced because of lack of personnel. And the responses needed to this are structural, to do with particularly the levels of payment of key people inside health services. And it's not something that a government that's facing economic stress, like, for example, the UK government or the French government are facing, it's not something that either of those countries are going to be able to deal with quickly. It's a very challenging situation, in my view. You will all have views on it. It'd be great to hear. I want to just say a word or two about the cost of living crisis, on which you know that I'm working. This really is widespread, and in all groups of countries, low income, middle income, and high income countries, the numbers of people affected by the cost of living crisis, and also the way in which they're being affected, the intensity of the effect, seem to be deepening in most places. It's not easing off. And this is despite the fact that there has been some stabilization in food prices and just a bit of stabilization in energy prices. But the underneath of all this is huge fluctuations, both in food and in energy prices on world markets. a lot of nervousness about whether the ongoing Black Sea grain initiative is going to be maintained. And within this volatility, real challenges. Now, people say to me, well, it can't be that bad because the financial markets have not sort of melted down again. But the analysis that we did this morning is the following. We're in a situation where the crisis is affecting people whose existences do not touch the financial markets very much. We're talking about poorest people in high-income nations, poor people in middle-income nations, and the people in low-income nations. And the concern that the UN Secretary General has, and we're going to be discussing that, I believe, this afternoon, is that it's really hard to get high-income nations to focus on the plight of poor countries at a time when their main emphasis is on curbing inflation and managing their own finances. And yet, of course, the low-income nations are experiencing very grave problems, but these do not actually very much penetrate into the decision-making consciousness of leaders and ministers of finance and so on from high-income nations. It's quite a tricky moment, and for United Nations Secretary General, who's one of the few leaders who will be speaking out internationally on the plight of people in poor countries, the difficulty is to find the hooks to get this concern about what's happening in poor countries into the mindset of particularly the G7 or the parts of the G20 that are talking to each other. The geopolitical context makes all this work extremely difficult. I'd like to be ready to make some more points about variants of interest, about global patterns, about long COVID, and about the cost of living crisis a bit later. I did want to mention two other things in public health that are a major concern. The first is a really unpleasant Ebola outbreak is spreading in Kampala. And the reason why we look at that is it's an urban outbreak, and they're always difficult, Ebola outbreaks in urban communities. We saw that in Monrovia in Liberia in 2014 as well. Second, is there some really tricky cholera outbreaks around the world at the moment. One is Kenya's Dadaab refugee complex, which is for refugees arriving from Somalia. There's actually anxiety about both measles and cholera, and measles is also causing problems in Zimbabwe, and cholera is causing major problems in Haiti. And just finally, there are 6 famines underway in the world today. They are the extreme food crises that the world is looking at. And the latest one to be added is Haiti, on top of the famines in Somalia, Ethiopia, Yemen, Sudan, and Afghanistan. Now, just like to tell you about Haiti, half the population is facing hunger. It's what we call the integrated phase classification of food insecurity 3+, and that's bad, but that's half the population, 4.7 million. 1.8 million are in what's called IPC phase 4, which is the emergency grade, and that's 500,000 more than was projected earlier this year. And there are 19,000 people in IPC phase 5, which is catastrophe, in an urban neighborhood in Port-au-Prince called Cité Soleil. Now, people are going to say, well, Haiti's a special case. It's had an earthquake or two and other natural disasters, and the government is in total crisis. And yes, absolutely. But what I'm trying to say to everybody is, when you are entering into a massive crisis globally, the countries that go into famine first will be the countries that have got all sorts of other factors coming together. But that's, in a way, the tip of the iceberg. And it is extremely important for us to be aware that the current crisis is very much likely to spread in coming 6 months. It's been triggered by the fragilities and difficulties revealed by COVID. It's being exacerbated by accelerating climate change. It's being pushed forward by multiple conflicts, particularly the conflict in Ukraine with its impact on global markets. And it's being accentuated by inflation. But this is the sort of epicenter of the current difficult crisis in the Horn of Africa. But we've got many other parts of the world where people are entering into deeper poverty and becoming malnourished. It's just that, unfortunately, in our global crisis response group, we've got a bit of a ringside seat on this. And the big challenge that's associated with that ringside seat is what is going to be done about it, how to help countries get through this. And that is the focus of our efforts today and tomorrow in a place called the Green Tree Conference Centre, which is a facility made available by a family living on Long Island that's given to the UN for this kind of thing. Right, so that's my brief introduction. Frank Atherton, please. Lovely to hear from you. Any sort of broad or slim reflections?
Well, David, on the broad ones, thank you very much for that kind of global view. I mean, it's always good to kind of get a view of everything else that's going on. You know, I mean, clearly we're all focused on COVID, but there's all of this going on. It strikes me they're interconnected things, are they not? And you know, it's very frustrating. I think Malawi is also on the list of cholera, a place where cholera has resurged again. You know, it's very frustrating. Yeah. 30 years ago, I was a district medical officer in Malawi dealing with exactly the same issue. And it is frustrating that, you know, countries still don't have the capacity to deal with these things systematically. So I hope your deliberations go well there, but I think there is something about the fundamental capacity. But on the COVID front, you know, in terms of the UK, I mean, it's really grappling with exactly the situation you described, which is high levels of community transmission, largely BA5 still here, but moderate and decreasing impacts or direct impact, let's say, on the hospital system. Which is, you know, reassuring to us all, but there's still harm accruing. And those sublineages that you describe, and we were very anxious about those as we watch across Europe what's happening. I liked the construct that was in the sidebar. Was it Claire Taylor with the Omicron soup? I sometimes talk about a smorgasbord of subvariants as well. But whatever we call it, I mean, they are worrying, and they do seem to have some vaccine evading possibilities. But you know, our great faith here still has to be in vaccines, and we're, as you know, I'm sure, David, getting on with vaccine boosters. I had my 4th yesterday. You'll be very pleased to hear. So that's all to the good, but we can't just assume that they will be the be all and end all. I do have a question for you, David, and it's this. I know the time is not right now, but at what point does WHO start to think about, you know, about COVID as one of many seasonal viruses? Because in the same way as you're describing USA, we have a resurgence of flu. It's an early flu season here by all, it appears to be coming our way. We've got a resurgence of RSV. So there's all of these other respiratory things, and we need to think about how we tackle COVID as a part of that. I just wonder where WHO thinking is on that. Maybe that's something we could come back to at a future meeting. You're right to flag that the other precautions. I mean, I spend a lot of my time talking to chief executives of health boards and reminding them that even though we don't have legislative requirements any longer to wear face masks or face coverings, it's within their gift, within hospital sector, within social care, to insist that people use these things. And you know, that goes down well in some places and less well in others. It is difficult to take the public with you, and I absolutely take your point about protecting the individuals. There should be no, you know, shaming of people who, you know, still feel that they do need to take on that extra protection. So a lot going on still. We're not out of the woods. I mean, none of us think that. And the prospect of long COVID, as you rightly said, obviously we're going to go on to talk about. I'm sorry I can't stay for the full hour this time, but really good to have that global overview, David. Thank you for that.
Oh, well, it's lovely that it's some help. Frank, here we go. The Director General of WHO summoned the emergency committee for one of their regular reviews of the COVID situation about 2 weeks ago. And he asked them straight up, is this still a public health emergency of international concern, or can we downgrade it? And there was quite a debate. And at the heart of the discussion was the following question. If we downgrade it from public health emergency of international concern to a national endemic seasonal virus, is this sending perhaps the wrong message? And the people concerned said, A, we're finding out more and more about this virus and its pathogenesis and the pathology it generates. So we need to just be a bit thoughtful about that. In particular, the long-term morbidities following infection that are being reported from some longitudinal studies. And secondly, we still have one country, and it's not just one individual country, it's a country with some neighbors as well, but China, which is working really, really hard to try to lessen the spread and doing it at considerable economic and political cost. So that too weighed in the thinking. And the end decision was we will keep it as a public health emergency of international concern and revisit again at the end of the year. So that's where it stands. And I'll try and find out a bit more, Frank, about what the inner thinking is, because I think it's relevant to your own discussions with other chief medical officers in the UK. So I'll get you more, but it's two things. One, there is at least one major country that is treating this as a public health emergency right now. And two, and there is just big worry about what is going to turn out to be the long-term impact of this infection on people's subsequent morbidity. Do you want to come back, Frank, on that or anything else?
No, that's really helpful. I accept the end of the year is a good time to review. I was thinking kind of early, spring next year, we'll probably in a better position to know kind of a bit more about both those questions. So so maybe that's the time when.
Yeah. Thank you. Now, Claire asks in the chat, could we provide reference on the combined strain? Yes, what I'd like to do is to just ask you to, sorry, it was Catherine wrote saying, Claire.
Yeah, sorry, David, Claire mentioned that there was an experiment that had been done in Boston that combined Omicron. And so I'm just hoping to get the reference for that so that we can be more informed.
Thank you very much, Kat. Nice to see you. Okay.
I'm just fine to get Kat. I'll pop it on.
Thank you.
Thanks a million, Claire.
All right, so let's go around and hear from others. I'm very grateful to you, Frank. And we've got 2 or 3 lines running in the chat. We got discussions on long COVID, etc. And I would like to invite in the following order, Ray, if you would like to speak, you welcome anytime. And I also would like to invite Claire Rayner and Claire Taylor to speak as well. And anybody else who wants to talk on long COVID issues, please do so. Then I would like to invite Marianne and others who would like to talk on the global crisis issues to come in. Be nice to hear from Joe Nichols. And Dirma, if you have got a good internet, be lovely to hear from you, sort of things you're dealing with. I'm glad to see Twee, you're on. Don't hesitate to unmute and signal, put your hand up or whatever if you want to come in. Anybody else, you're welcome. Ray, Duncan, Doctor, you have the floor.
Hi, nice to see you all. How are you all doing? I probably don't have that much to say this week. I've just come off Indie Sage where we were talking about the things we've already talked about in this meeting, longer term cardiovascular issues, new publication, relatively new publication just published a few weeks ago in Heart, which is a big cardiology journal, looking at the increased risk of heart attacks, thrombotic events and deaths in the UK population, and confirming pretty much the same findings as the Americans have found, the Swedish have found, and the Europeans have found. On a personal note, I suppose one of the things I wanted to touch on today was a very specific complication that we're seeing quite a lot of in long COVID and in individuals with long COVID. So as you're aware, there's 200 symptoms potentially. The top 4 are fatigue, brain fog, PESI, which stands for post-exertional symptom exacerbation. So if you try and do too much, you end up having a crash and then you end up often bedbound for several days, feeling very unwell. And the 4th is something called dysautonomia. And we're seeing quite a lot of post-COVID dysautonomia. We're seeing it in around, depending on the paper you read, around 40% of cases. What that means is COVID is disrupting or damaging or inflaming or all of the above our autonomic nervous system. So that is the nervous system that is underneath, is under our unconscious control. So it's the nerves that supply our bodily functions. So our heart rate, ability to control our heart rate, our ability to control our blood pressure, our temperature regulation, our sleep cycle, our ability to control our gut, to swallow without vomiting, to control our bladder. And we're seeing quite a lot of this, more than we've ever seen before. And from a cardiovascular point of view, we're seeing a lot of a condition called POTS, which stands for postural orthostatic tachycardia syndrome, and a similar condition called IST, which is inappropriate sinus tachycardia. Now, this is quite easy to miss, and it's being missed quite a lot. And I know that there are different ways of approaching this. And I know that certain medical colleagues, when they see perhaps a sinus tachycardia in an individual that seems fit and healthy, assume it's, and you know, they've done their blood test and they come back normal, assume this is nothing to be concerned about, assume it might be related to anxiety. The chances are it's probably not. Now I'm saying probably because I don't have the data, but we do know that 40% get this. And really a very, very simple test can help you diagnose whether this is a dysautonomic function or not. And that test is called a nasoline test. And you lie your patient down for 10-15 minutes, you take their heart rate, their blood pressure, and you should probably take your oxygen levels lying down as well. And then you stand them up with their shoulders against a wall, so if they feel unwell, they don't fall over. And you simply measure their heart rate and their blood pressure and their oxygen levels every minute for 10 minutes. And if they get a massive spike in their heart rate that is sustained without the blood pressure dropping, then they have clear evidence, and it has to be over 30 beats per minute technically, but we're not going to split hairs. They have clear evidence of dysautonomia, and it can be very disabling. It can get to the point where where people, although it's not dangerous in the sense it's not going to damage your heart, it's not going to make your heart stop, it can be very, very disabling for individuals. I've seen 3 such patients in a week. One, a child that is now unable to go to school, an older child. Another is a young lady who, again, is happy for me to share anonymously, who has been very, very profoundly affected with heart rates of almost up to 200, trying to stand up. She can't stand. She couldn't even complete the nasoline test for very long. She used to be a sports coach. She can't walk very far. She's off sick. She's had to move back in with her parents. And initially when she was assessed, she was told she had a fear of standing up. And now she's under a dysautonomia specialist and she's actually getting treatment, and I'm hoping that she will start to get better. But it's just something that it's, again, a case of if you don't know about it, you won't look for it. If you don't look for it, you won't find it. If you don't find it, you won't diagnose it. If you don't diagnose it, you won't be able to treat it. And it's something that is not curable, but it is treatable. And there are drugs available that can help. And there are other lifestyle measures that can help. And if anybody who has, I don't know if anybody in the call has long COVID or feels like they have these racing heart rates, the POTS UK website has got lots of good information. Dysautonomia International has also got lots of good information. And they also have links to specialists around the UK and internationally that specialise in this condition. So that's, I guess, all I wanted to say this week.
Well, Dr. Duncan Ray, that's hugely important. Karen Palmer asks, how are you treating dysautonomia? And you could perhaps answer that in a second. I'd just like to say, because we've had the opportunity to discuss this briefly, that I think this is an issue that I would like to take before my colleagues in WHO. They're not on the call today, but I will make sure to get this message through, as it'd be useful to get some comparison internationally across nations in order to try to build up a consensus perspective on this issue. So I will, with Catherine, who's here, and Mahika, make sure that we get the message through, and so on. Catherine's just acknowledging that she'll do that. Iman wants a link to the website. I don't know whether you want to say anything now that these questions are coming in, Dr. Ray, but just come back again if there's a couple of other things you want to say.
Okay, well, maybe Claire, if Claire's going to speak next, she could answer some of these too, because she is a POTS specialist.
Right. Okay. So that would be the Dr. Claire Taylor comes next. Hello, welcome.
Hello, hi
join.
David. Hi. Thank you for summarising out everything that's going on at the moment, because there is a lot going on in the world. It does feel a little bit like the chickens are coming home to roost for our very frivolous lifestyles over the last 20 years. But yeah, it's a good overview, thank you. With regards to POTS, so the specific questions on POTS, I think it's higher than 40%. So the studies are very variable, but I would say that when I have patients in my clinic, it's very unusual not to have POTS. And that can be on the spectrum dysautonomia. So POTS is if your pulse goes up by 30 beats a minute on standing. So the original diagnosis was done in, X amount of people, and they set it at 30 beats per minute. But, if your pulse goes up by 28 beats a minute and not 30, then it's called orthostatic intolerance, but it's the same thing. And you have a spectrum of people whose their system just doesn't react normally to being upright. And there was a paper out recently where about 70% of the patients in the study had long COVID, POTS with the long COVID. And after 2 years, it had gone. Mostly, there was a bit of orthostatic intolerance left, but interestingly, the cerebral blood flow was still reduced. So the POTS is actually affecting the blood flow to the brain. And when the POTS goes, so it's a post-viral POTS, and you would hope that you could support people through treatment, and that might then, as we've seen with this paper, it might then go after a couple of years, but we're left with the reduced cerebral blood flow, which is important. Treatment-wise, there's loads of drugs for POTS. Most people need at least one, possibly two, sometimes three. An easy one for any doctor to prescribe if there's no contraindications is bisoprolol, beta blocker. Should be available in lots of countries, I would hope and think. Bisoprolol, small dose, and as long as somebody doesn't have a very low blood pressure and can tolerate it, that can be enough just to stabilise the sympathetic nervous system, because the sympathetic nervous system is usually the part of the autonomic system that's went into overdrive, and we don't know why. There might be antibodies, there might be inflammation, there might be these microclots, but it's in overdrive. And it's a bit like if you've got a clutch in your car and you're trying to find the bite. I know there's lots of automatic cars now, but when you find the bite in a car and so you don't stall it, and so that you get it just right for moving off, that's what the autonomic system is like with the sympathetic and the parasympathetic. You want it to be in balance, and if the sympathetic is in overdrive, you then rev the engine. And that's where the pulse goes up and the blood pressure goes up and people start to feel dizzy. So beta blockers, easy peasy. Fludrocortisone is something we commonly use in the elderly who just don't keep their blood pressure up as well as they once used to. It's pretty safe medication. Ivabradine is a great drug. It's a funny channel blocker. So there's a funny channel in your heart. And don't know who named that, but I think they were having a bit of a laugh. And Vabradine specifically blocks this and doesn't drop your blood pressure. And is more specific. It was actually used as an anti-anginal drug, but is really good in POTS. And there's a few others as well. But as a getting started, the drugs are good, they're effective. And, you know, I find it strange that we diagnose people with POTS where their heart can race to 200 beats a minute and not give people any medication. That's strange. You know, if your heart was racing at 200 beats a minute for any other reason, you would have 10 doctors around you trying to ply you with, you know, drugs to get it down quickly. But as soon as, you know, the ECG comes out as sinus, everybody goes, oh, well, it's only sinus. So we don't need to treat that. You need to treat it because your heart's working far too hard. And as I was saying with the recent paper, the blood flow is not getting to the brain. So I think that's where the brain fog comes in, and all of these symptoms are really disabling to people. So in my clinic, they quite often turn up in wheelchairs, but the reason they're in the wheelchair is because of the untreated POTS, and the reason they've got the brain fog is because they've got untreated POTS. So if we could get better at treating that and get some sort of international agreement on it, I think we could really improve people's quality of life. And I think a lot of the severe ME patients have got untreated dysautonomia that's went on for a very, very long time. And I think getting in there early is super important. So if somebody's sympathetic system is going bananas, getting in there within the first few weeks, not the first few years, is important. The other thing I wanted to say was, I hope this is okay, talking about, you know, people's assessment of risk now and COVID and wearing masks and that sort of thing. My take on it is that most people take their advice from people they know, from the media, but very much from what they're told in the media. And when you get words like mild bandied around and over and over and over again, that sticks. And actually, what I'd want to say to people was, first of all, if you got long COVID, and people tend to be off work for quite a long time with it, could you afford to have no income for a year or 2 years? And the second thing I would say is, would you smoke a pack of 20 cigarettes a day? Because the damage that COVID does, it does it silently, does it to the blood vessels. And if you wouldn't hand your kids a packet of cigarettes, and I think most of us here wouldn't, and most people watching wouldn't, I'm a bit confused why we're so chilled about this virus that affects our blood vessels. And maybe the messaging just isn't quite right, David. You know, I think the messaging is not right, and we don't want to terrify everybody, and we don't want to say nobody can have a life. And as somebody said in the chat earlier, there's a trade-off. Of course there is. You know, I might decide I'm going to go to the cinema. I'm going to wear an FFP3 if I go to the cinema, but because I've had COVID 3 times this year. But you know, I'm going to think, is it worth this trade-off? And we're currently in a situation of a trade-off. We're in a trade-off with the economy. Fine, we need an economy, but we're also in a trade-off with our bodies. And this may or may not be a trade-off that pays off. And if it doesn't pay off, our already struggling health service is in real trouble. And the last thing I want to say is, I've put the link in the chat to the experiment that was done in Boston. So they took the original COVID strain and they combined it with Omicron, and they made a strain that was 80% lethal in monkeys. Now, it's a very high level lab, you know, that's...
I think it's mice.
Sorry, mice, sorry. Yeah, so it's a very high level lab, so it's not, I'm not...
Claire, you're on mute.
Sorry. Oh, I'm back, sorry. Sorry, yeah. Mice, I apologize. So it was 80% lethal, and of course it's mice, it's not people, but I suppose my thing I wanted to say was, what if that happened in nature? Nobody knows. So the lab got a lot of criticism saying, oh my goodness, you've created this monster variant and it's in a lab. It's a very, very high security lab. But I think it shows what can happen with these variants. And yes, we're currently sitting in Omicron, and yes, we've got bits and bobs and they're getting more transmissible, and which is bad because then you get COVID more often. But actually, I think that experiment's really important. Anyway, I'll get off my soapbox now.
No, but your soapbox, you were on your, what you were saying just before about the potential impact of all the suffering that is associated with damage to vessels that is caused by this virus in a certain proportion of individuals. This is so important. And you all of you, Ray, yourself, Claire, CLARE, and those you work with, in my view, deserve immense appreciation from us for basically holding on to this and saying, look, there is something happening here. And with these long-term follow-up studies coming through, the UK one that Ray mentioned, plus the work that you've got on how important it is to identify POTS and to treat it, and your statement about how people with POTS can end up actually involuntarily disabled for a very long time, yet they don't need to be. This is super, super, super important. And I think all of us appreciate that you're prepared to share your groundbreaking work and all the challenges that go with it with us. And everybody, you know, this is a private group. And I think I want to stress that we do enable others to see what we're discussing, because it's virtuous stuff and we're not ashamed of it. But again, don't hesitate to say to me if it inhibits you or concerns you that we do make these discussions public.
No, I want people to hear this stuff, David, and
cool.
I'm appreciative that you give us somewhere to say this, because actually I haven't been on social media for a couple of months because the trolling just got so bad.
I heard you got very badly trolled.
Very badly trolled, David. I'm going to go back on, but I needed to take a bit of a break from it. And I think, you know, if we can give people alternative sources of information, I do think what people are being told at the moment, you know, people are not scientists and not doctors, and they take it from media. That's where they get their information. And I think maybe we need alternative sources so people can make their own decisions about what sort of masks they wear, etc. But yeah, I'm hugely grateful for again letting me speak. Thanks.
Thank you. Anytime. Claire Rayner, it was through you that I met this fantastic community of people, and super grateful to you. Please, if you wish to make any comment, please do so now.
I think, you know, we've heard a lot. It's been really useful tonight. So I haven't got anything extra to add to that. Just, I think, to reinforce that early treatment of these complications can make such a difference to how people function. Very simple drugs sometimes, and that don't need to be even given for a long time. So if we can just, prevention is best, but if then people do get the problems, it's the secondary prevention, the early treatment. But I'm just very, very cognizant, as you've said, about the whole sort of ecosystem of the world at the moment, and how I think we've all got to tread quite carefully with everything, and, you know, so thank you.
And we do, because as you pointed out, there are some people who want to find us perhaps stepping into difficulty and then want to tell us off for it. It's a tricky time, and we all, I think we need to stay as close as we can.
Thank you.
We're doing this for nothing other, as I understand it from this group, than a genuine wish to have some greater equity in health and well-being in our world. I wanted to invite Indira Moi just to let me know if she'd like to speak. You don't, just if you could unmute at some point and just say, I'm here and would like to speak. I don't want to embarrass you. So that's just if you're hearing me. Joe Nichols, we haven't heard from you for a bit. And if you're hearing me, it would be really nice. COVID or indeed other stuff as well. Joe Nichols, please, working in Nairobi, but covering Somalia et al.
Thank you, David. Yeah, no, I just got back yesterday from Mogadishu, and there's been, I mean, the focus is very much on the drought and the fact that about 300,000 people are at risk of dying of hunger by related to not having water, but also all of the other things you're talking about. And the link to climate change is extremely strong. This will be the 5th failed rainy season. And a country like Somalia creates about, less than 0.08% of the global emissions of carbon. And it is one of the most vulnerable countries in the world to climate change. And if you take a small town in the south of Somalia, like Baidoa, they have, there's 63 water boreholes in that area, and 55 of them have dried up. So there are 700,000 displaced people living there. And that much of the water that would normally be accessible has just disappeared completely. So there are already people dying of hunger. There are already people dying of diarrhea and measles. About 3 million livestock have already died as well, which means that the future of the kind of economic side of things is already dramatically affected. So I think the sort of nexus of everything coming together, the cost of food increasing, the cost of energy increasing even, but and then climate change plus the economic impact of COVID and the war in Ukraine is enormous, and it is affecting the most vulnerable people more in the most vulnerable countries. So the people who have links to rich people somewhere else, whether they're in Somalia or in the United States, they may still get remittances. But the people who are the most marginalized or the most vulnerable don't have that kind of access. And it is those people that will be affected first. So I think it sort of encapsulates a lot of the different messages you said in your introduction. I know it's not, the COVID situation is deteriorating a bit in Kenya at the moment, but the fixation and the focus has been very much more on the drought in this region at the moment. Thank you.
And apparently, thank you, Joe, very much indeed. Apparently, if you travel north in Kenya as well, towards Marsabit and so on, it's pretty, conditions for people there are really difficult. And
Yes.
relief, relief is getting through, but people are holding on by a lifeline, and we know that they'll get ill, and then it's the diarrhea leads to deeper malnutrition, and often then it's very hard to help these children come back, even if you've got food, because as with all these other things we're talking about, the systems inside their little bodies get unbalanced, and you can lose them very, very quickly, in my experience. I don't know what it's like from your UNICEF colleagues and so on.
Definitely northern Kenya is very affected. But the point you were making earlier about the integrated phase classification, which tells you how food insecure areas are, that's done in Somalia. So we have very good information about which areas are the most affected and can see a little bit what that will mean in the future, both because we have the health data and the nutrition data.
So that's everybody, this new classification of food insecurity, which is I suppose almost the same as hunger. New classification requires a government being part of the classification, because there'd been quite a lot of concern in the 70s and 80s that northern nations were talking about famine and so on in southern nations and using statistics that were contested by the governments. And that's one of the reasons why all of us worked on this thing called the integrated phase classification. But as Joe is saying quite delicately, and I will use the same delicacy, there are some countries in that region of Africa called the Horn of Africa that are not permitting IPC assessments. So that means that the numbers are not available for what's happening in those countries. And we collectively expect the situation in some of Somalia's neighbors to be worse, perhaps, than it appears to be. Is that right, Joe?
Yes, that is absolutely correct. Yes.
And I mean, we've got a very, very bad war happening in that region as well. And what I say, Joe, more and more now is that there's stuff going on that perhaps under normal circumstances would get into newspapers, but because things are sort of hot because of Ukraine and because of some of the political ups and downs in Western Europe and North America and so on, perhaps that's leading to less attention in the newspapers to the fact that in terms of crisis, this is far and away the worst since really the Second World War. It's certainly much worse than 2008. And it's hard, this is going to be our discussion today, it's hard to get this stuff to stick. And I wanted to go to Marianne, who's written a comment about it, and we talk about it quite a lot, about if you were in my shoes and you were trying to advise UN bosses about how to get greater attention among G7 and G20 and other leaders to this multiple crisis, what would you do?
Well, that's a tall order, David, and you're there and I'm here. And what I can do here is somewhat limited, shall we say, sitting in Folkestone, but there you go. What I would do is to use what's around in the UN and use, the first thing is to go, we have to go back, look forward. We go back to what's agreed, and that is the 2030 Agenda on Sustainable Development. It's all in there, and it talks about interlinkages. And if we want to make progress, we have to interlink between various sustainable development goals. I could argue with you on what, I'd say water is more important than food, and you'd say the opposite. They both need each other. You can't have food without water. And if you've got water, you have to have food. So the point is to use the interlinkages in trying to look at a multiple crisis. It's a series of crises that go round, and they're multiple entry points, but they're all crises. So that is the first thing. The second thing is to use the people you have. Now, one of the people you have at the moment, he may not have been my best friend at times, and that is the current President of the General Assembly. That's Chaba, I've forgotten his last name at the moment, who was instrumental in getting the SDGs. He's a Hungarian. He was the
You've changed it.
Sorry,
Good.
me. Okay, I didn't change anything. He was Kurosi. Chaba Kurosi was instrumental in getting us the SDGs. He's now the President of the General Assembly, and he's got the knowledge. He's got the know-how, and he knows how to negotiate. So bring in the people you've got, and also it's a question of weighing up. You've got all these balls in plates on sticks, on poles. You have to help with the one that's wobbling most. Now, COVID was wobbling for a very long time. Now it needs less attention maybe than some of the others do. So it's a question of how we look at things, and you can't just look at one thing. We know about the problem of Ukraine in Europe. They don't know about it so much in Africa. Africa's got its own problems. We've all got problems, but it's just, let's get the issues on the table and start moving forward. And there are two things to move forward to. One is in 2023, there's going to be a summit on SDGs. We start on it now. And in 2024, we have the summit on the future. And from the point of view of the UK, it's a question that we have to get the government we have, as long as we've got it, to act immediately. And it's appalling that our Prime Minister, nor our King, is going to be going to COP27. Thank you.
Thank you very much indeed, Marianne. And just to say that that is very much the style that I am proposing to use. The interconnection seems to me to be really, really important. Finding the people and places and venues where we can get movement is key. Thank you for that suggestion, also with regard to the destination points. And just the other thing we agreed to do amongst many of the different agencies is to really be much better at focusing on the countries that are in greatest difficulty. So we try to not dig down. Okay, everybody, thank you very much indeed. As I say, we are hugely helped by having these conversations, quite broad in focus, no doubt. But that is, I think, the right thing for us to be conscious of, which is the interconnections of these crises, the importance of science in helping us to understand what the nature of the crisis is, and that's particularly the case with regard to long COVID. Also, it's the case with regard to understanding the starvation happening in our world that Joe was referring to from Mogadishu, or from Somalia. And also we need good quality analysis and science to help us identify strategies that will be the most effective. And that's why I really appreciate Marianne's constant scholarship in thinking through which direction to move in. I send apologies for absence from John. He's got something else on today. And I'd like to move to Catherine just for some final remarks before Mahika for closure.
Hi, everybody, and happy Friday. David, thank you so much. The sort of expansive nature of this conversation, I think, was so incredibly useful to me. I'm really looking forward to it. Thanks for everybody's comments. Thanks for that paper, Claire. I'm really looking forward to reading it more carefully. That kind of thing is super interesting. Thanks to all of the people who have continued to come. The long COVID conversation continues, and I'm glad we're continuing to focus on it. I just want to remind everybody on a totally different note that all of these OOBs are recorded and they are then made public on 4SD's website. We've been putting notes into the chat, and there are pieces that are also put onto YouTube and other spaces. So if you want anything redacted or changed or edited, please feel free to write to me and or Mahika, and we will make sure that that happens for you. In the meantime, have a happy morning, afternoon, evening, weekend as you go forward. Wear your masks, wash your hands. I don't mean to be such a mom about it all, but there you go. Back to you, David.
Thanks. Mahika, please.
So this was the 125th session of the Open Online Briefing, which is quite a milestone. I think it's amazing. And thank you all for joining and making and creating this amazing space for these conversations. Our next briefing will be on the 11th of November on Friday at the same time, and I will also tweet about it before the session. Thank you all very much.
With that, I say bye-bye as I run out of this hotel. I'm a bit late with my checkout. Bye-bye all. Thank you.